A very big hello to all my dear students. So, how are you all? Welcome to the T2O series in your favorite channel, You and I. Okay, so today we are going to discuss a clinical vignette on a very, very important topic asked in all types of exams that you've attended. Okay, so let's start reading the question. A 50 years old male patient presented to the emergency department with persistent fever, cough, and worsening shortness of breath, tested positive for COVID 19. I think that's the biggest hint you all already have. He had fever of 101.2 Fahrenheit, tachypnea, and bilateral expiratory wheeze. Chest radiograph revealed bilateral reticular interstitial opacities consistent with a viral pneumonia. So all the features of the COVID-19 is depicted here. On the third day, he was intubated and transferred to the intensive care unit due to acute respiratory distress syndrome. Now, eye point of view, all this is a background, of course, but now comes the most important part. On the day of his discharge, that is on the 12th day, he complained of sudden onset of loss of vision in his right eye. On examination, right eye pupillary reactions were absent. Rest of the anterior segment was normal. On fundus examination, retinal whitening with cherry red spot. I think it's obvious what we are talking about. So optic nerve has slightly indistinct margin, the most probable diagnosis. Okay, so all of you, what can be the most probable diagnosis in a patient who is COVID-19 positive, presenting with sudden loss of vision, sudden onset of loss of vision? Of course, fundus showing cherry red spot. I think we all know the answer. We are talking about central retinal artery occlusion, right? Okay, so this is the presentation, and this clinical slide is very, very important for you all. Asked so many times in the exam. This is your cherry red spot. What are the 2 points that you will remember exam point of view? That there are two main manifestations for COVID-19. Ocular manifestation I'm talking about. So COVID positive patient, two ocular manifestations, very, very important. One, of course, is follicular conjunctivitis. Okay. So viral conjunctivitis is follicular conjunctivitis. And whenever they ask you which is the most common ocular manifestation, we will answer this only, right? Okay, and next, of course, is as depicted in the history itself, it is your CRO, central retinal artery occlusion. Okay? Okay, now let's discuss a very interesting thing here. When you say cherry red spot, it's a very, very important is the differential diagnosis of cherry red spot asked in your exam again and again. So when you talk about the differential diagnosis for cherry red spot, we can divide it into two broad headings. Learn in my way. First, of course, is CRAO, that is central retinal artery occlusion. Second, क्या बोला? Berlin's edema. I hope you all remember Berlin's edema is also called commotio retini. So we are talking about blunt trauma, correct? Where there is edema at the macular area, and there is one point where there is no edema, and that is your cherry red spot. And what is the third? I'm making things simple for you. Just say depositions. So when you say depositions, we are including all the sphingolipidosis and gangliosidosis. So I'm talking about Tay-Sachs disease. I'll just speak here. Tay-Sachs, Niemann-Pick, Gaucher's. Please, this is debatable point, but yes, even in Gaucher's, you do get cherry red spot. Krabbe's disease, GM1, gangliosidosis. Okay. All these are the causes of cherry red spot. Okay. Even in Sandoff's disease, in sialosis, it's all included. Okay, no confusions. Take care. Once we know this, okay, one more point I would like to add here is GM1 gangliosidosis. It is the type 2 which has cherry red spot, not type 1. Keep in mind. If you want, you can note it down. Okay, so once we know the DT of cherry red spot, very, very important thing is why are you getting this red spot? Do you know this interesting fact? Why do you get this red spot? Think yourself one by one. When there is edema, okay, the very center of your fovea, there are no blood vessels. Foveal avascular zone, correct? So there is no edema there. So what happens? The background choroid is shining red. So you are getting all white area due to edema, but that point it is the background choroid vasculature which is shining red, which looks like cherry red spot. This is the reason for CRAO. This is the reason also for your Berlin's edema. What about in depositions? So keep in mind, when all these depositions that we are talking about is taking place in the ganglion cell layer. And if you are thorough with your anatomy, you will know that ganglion cell layer is again not present at the very center of the fovea. Correct? So number of layers normally in the retina is 10, but when we talk at the very center, it becomes only 5. Right? So because it is not there, again deposition is all around, but that very area there is no deposition and the background choroid is shining red. So that is the cause of cherry red spot. So you should be very, very clear about cherry red spot. It's a very, very important topic. Come to the next slide here. When you're doing an angiography in this patient with a CRAO, what do you see? As you can see, very delayed filling of the arteries. Okay. Of course, the choroid filling is normal here because it is only the arterial occlusion, but there is a delayed filling that is being depicted here with the arrow. See, all this is dye. The white one will dye, and if there is a black part that you are seeing that is not filled with dye, correct? So there is a delayed filling. Just keep this in mind in an angiography. Okay, so angiography is showing you a delayed filling. If you have learned this, another important thing is you can also go for electroretinogram. And if in CRAO has caused retinal ischemia already, then due to the retinal ischemia, what you can get is your diminution of decreased B wave. Okay, we get a decreased B wave. So I hope I don't have to remind you about ERG. I have discussed this in siderosis also. ERG, what are the wave? A wave, B wave, and a small C wave. So A corresponds to photoreceptors and activity, and B for B corresponds to bipolar cells. Please do not forget this. This has been asked in exam. Right, all of you? Come to the next slide. What is this? So you see what happens. You may have a patient suffering from central retinal artery occlusion, but he is not blind. His vision has not gone. So what is the vision has not diminished or slightly diminished, not gone to 6/60 or less. But why? Why it is happening? Why is not? Because common sense, by chance this patient has a dual blood supply. Okay? So please remember with me that 14% of world population has dual blood supply on the macula. I want you all to please make this diagram so that you never forget. Okay, simple diagram to depict and keep it in your records. So another artery, the second artery which is supplying the very center of the fovea, this is cilioretinal artery. Write down here, cilioretinal artery. Devasio cilioretinal artery is a branch of, it is a branch of short posterior ciliary artery. Okay. And if this is supplying the center of the fovea, that means this much of vision and this much of field is preserved. Why? Because cilioretinal artery is only supplying this area, not the whole retina. Rest is gone, but the central vision is preserved. The patient retains his central vision. And this type of visual field, where there is a central vision, what do you call it? Tunnel vision or tubular vision. Okay, so tunnel vision or tubular vision. If I ask you what are the other causes of tunnel vision, let me remind you, it can be late stage of retinitis pigmentosa, right? Or it could be, as you have seen in your macular sparing homonymous hemianopia, that means occipital lobe lesion. Any other reason? Quinine toxicity, vigabatrin, even that can lead to constriction of the visual field. This was your NICT exam question, right? So keep in mind, you have to learn the DDs of tunnel vision or tubular vision. Right, all of you? Yeah. So that's it for now. Thank you so much. And before we end, as a protocol, let me share a thought for the day here. Please remember, hope is a decision. Okay? Always be hopeful. And a person who has hope can reach anywhere. So all the best to all of you. Stay blessed and keep smiling.